So this is our agenda for today, and welcome, of course, everybody to today's AMCHP policy call / COVID town hall. Jonathan, our CEO, is going to provide everybody with a quick welcome, and then I will go into a legislative update. We are joined by our guests, our friends at MCHB and CDC, and then we will have a presentation as well from our friends at ASTO about VoteSafe and the VoteSafe project there. So actually, before I go over to the legislative agenda, Jonathan, I'm going to turn it over to you.
Thank you, Amy. Can you hear me?
You're a little bit low, volume-wise, I mean.
Is this a little bit better?
Yeah, thank you.
Okay. Thank you, as always, for leading us in these conversations, these very important conversations, helping us to stay connected and plugged into things that are going on related to COVID, but then also these opportunities to share a bit about what we're doing, a bit about what our partners are doing to keep our membership engaged. So thank you, Amy, Jessica, and your team for all of that. Just wanted to welcome everyone. I have not had a chance to be on the last couple of calls because of conflicts, but I really do appreciate all of your work, all of your effort. And as I mentioned earlier on, I'm just so appreciative of you and very proud to be to represent you in this capacity because of all you do. I've had a chance to get to know and engage with most of you, and even prior to COVID, I was just very proud of the work we were doing. I'm even more so proud of the work that you're doing now, because you're really navigating some very challenging and difficult times, and you're doing it well. And you're sacrificing a lot to make sure that we're all safe, that your communities are safe. I just really appreciate all that you do and the folks that you represent. I sure appreciate your efforts as well. So I wanted to start off by saying thank you and just welcoming you to the call. I did also want to briefly address a note that has been out in the media a little bit. We're doing our due diligence to kind of figure out what things mean and how we want to respond and how we can continue to do our work and also support you. But recently, I guess back in June, AMCHP released a statement around being all in to how we address and support equity by really focusing on anti-racism and the impacts on health outcomes. And there's been a recent executive order around how we impacts the use of federal dollars in those trainings, and we are working through again what that means for our work. But wanted to just take the moment that we had on the call to thank you for your work in this area. We still believe this to be very important and necessary work that will significantly improve the health outcomes of women and children that we serve. We are very appreciative, as I mentioned earlier, of your interest in this work, and through conversations that we've had with many of our members. Health equity is of great importance to you as well, and we're just thankful that racial equity is one of the areas that you've chosen to focus on and support and support the health equity conversation, because you know how central that is to that work. So we again are very appreciative of your bold leadership on that. We do feel it's a little bit disappointing and concerning direction, but we are committed to doing this work thoughtfully and well. And the people that we all serve deserve that from us. And the urgency and intentionality that we've been moving with on this issue hasn't changed. We do, however, understand that this may place you in a difficult position. We know that this makes an already challenging time more challenging for you to do this important work, and we're so sorry about that. But the AMCHP staff enjoys our close relationship with our members, and please know that AMCHP is always here to listen and brainstorm with you. That some of your work in health equity has happened in association with efforts from AMCHP leads or partners on, and it means a lot to us too. We've been so encouraged to see the energy and passion for health equity. For our part, much of the work that AMCHP is doing in this area is not supported by governmental dollars. So we're planning on continuing to move our work forward in that way, but being very mindful of the need to ensure that no funds are being commingled. But when in doubt, we've been encouraged if there is any gray area that we reach out to our program office, our project officers, to get some guidance on how we move it through the right processes. And we would advise you to do the same. If there is any question or doubt or gray area, please be in contact with your project officers. Our board is going to meet at the end of this month to discuss next steps, how we adjust our approaches, and any ways we need to adjust and think about and communicate to our members. So please stay tuned for that. But I did just want to take the time, since we have a number of you coming together on these calls, just to thank you again for your leadership. Thank you for your support of this work. We're excited to continue this work with you. We just have to figure out what that looks like as we move forward. But again, thank you again. I'm looking forward to working with you, and I'll turn it back over to you, Amy.
Great, thanks so much, Jonathan. All right, we actually have quite a few items in the legislative update today, so follow me along for this little train ride. A few weeks ago, I guess, was it just a week ago, but it feels like a week ago, the House passed a new COVID relief bill, another HEROES bill, which was sort of meant to be reflective of some negotiations that have been going on since they passed the big HEROES package in May. This was sort of like a HEROES light, let's say, because it was less total money overall. So we thought that was a good sign that negotiations were moving along, and there was a lot of exciting things in this bill. Again, it only passed the House, this is not law, but I do want to point those out. So included in this bill was significant support for HRSA, including an additional $500 million for the Title V MCH block grant, which we were thrilled about. It wasn't actually in the original HEROES bill that passed in May. So we do feel like the message has been, received by Congress that the Title V block grant plays a really crucial role in the maternal child health response to COVID, and that it's a easy and flexible way of distributing aid as well. It would put the money through SPRANs, which I think was the right thing to do, because then this way states wouldn't be held accountable for the match part of it as well, and it would allow MCHB, to distribute these funds as needed to states that are feeling the greatest need. It also included significant support via CDC for, state, local, territorial, and tribal public health departments, for vaccination campaigns, and also there was $100 million in additional funding for the MCHB home visiting program, which this piece was actually in that original bill, but we've been really supportive of that throughout. So we were really excited to see that those important maternal and child health provisions were included in the bill, and we thought, here we go, like we might finally get a COVID relief bill. And then the next thing I wanted to share is this it was a letter that Speaker Pelosi sent to her colleagues, but it outlined where they have been making progress in the negotiations and where some of the sticking points still were. So UI, state and local funding, the child tax credit, testing and tracing, and just the overall level of appropriations. But then I guess, again, because time moves at different speeds during this period. So 2 days ago, there was also another interesting where sometime in the afternoon, the president announced that he was ending all COVID relief negotiations. I think there was a lot of backlash to that announcement. So then a few hours later, he announced that he would be supportive of sort of piecemeal support for certain sectors. So where that leaves us now, again, I think a lot of blaming going on. I think there, because of political considerations right now, being that we're only, 26 days out from the election, both parties probably feel like they can get a lot of mileage out of blaming each other for the failure of these negotiations, but we know that's not good for the American people. So, in terms of our advocacy efforts, we are still pushing for a COVID relief bill to get done, and we are making it clear that we are very appreciative for the additional funding for Title V and MCHB that were included in the last bill, and that we hope that those will remain. Of course, there's talks that, if party control changes in the Senate and or White House, that there'd probably be some sort of bigger stimulus package that's being put together. But we know a lot of these provisions, they can't wait several months either. So we will continue pushing forward. But this is the latest. And again, this is, just the update as of the past day or two. Could all change by the next time we meet. So the other good news, though, was also on September 30th, the Senate passed a continuing resolution to keep the government funded through December 11th. And so that was signed into law. So no government shutdown right now. Phew. That means that the next big movement on appropriations will be around December 11th. A lot of conventional wisdom will say that it'll probably be another short-term CR or continuing resolution at that point. Again, the way that they go with that will depend on how the elections go. But the other significance of that is because there's not as much legislation moving for the rest of the year, December 11th also becomes like a target date for a lot of other moving pieces of legislation that we care about, because likely the chance, especially in the Senate, given the way that they're structured and the rules there, may not be able to pass a lot of like small bills that we want to get done before the end of Congress. But if they combine everything into one massive package, that gives it a better chance of passing. And so I bring that up because some of the other important, no, I think I lost some slides. Okay. So I'll just tell you about it. Some other important legislation that has passed recently that we really care about include the Helping Moms Act, which was a bill that was bipartisanly agreed to, passed by voice vote in the House, would give states the option of extending Medicaid postpartum coverage to 12 months. So a state could just use their option to do that, which would, obviously make it a lot easier for states to make that change. And a lot of states are already contemplating it and working on it already. So getting, a bipartisan vote on voice vote for something that essentially expands Medicaid coverage in some ways, no small feat, and we were really excited. It's been a big priority of ours for the year, not over the years. We didn't just start that this year. And so the next, obviously, the next step is to get it passed in the Senate. We're having really positive conversations with the Senate, but again, we're kind of getting this indication that nothing's going to happen before December 11th. So between now and then, we'll be doing some more education on the importance of this policy change, but we are really excited. And even though the bill that passed isn't everything we would have wanted in postpartum Medicaid extension bill, it's a tremendous step forward, and we can always build more in the future. The other bill that passed was called the, Maternal Health Equity Act. It's HR 4995. And this is a combination of several bills, mostly grant-funded programs, so as opposed to like a Medicaid-related change. And it includes making AIM, the Alliance on Innovation in Maternal Health, its own standalone program. It would also provide grants for training for obstetric care in rural areas, pregnancy medical homes, and a few other, it was a combination of a bunch of different policies that we've been supporting to improve maternal health. It's pretty identical almost to legislation that has passed out of the Senate Health Committee. So the only sticking point there is that the language, when it passed in the Senate Health Committee, not on the floor of the Senate, it was included in a much broader bill called the Lowering Healthcare Costs Act, which had a lot of other provisions that provisions that are like unrelated, things that we aren't really tracking as a AMCHP and public health, and a lot of stuff related to like physician reimbursement. But the actual provisions related to maternal health were very generally liked and agreed upon. So pulling those provisions out of the bill would lose sort of a sweetener for that overall bill. So there's reluctance to do that right now. And because the members of Congress who want to pass the larger bill want to keep the maternal health provisions in to help get people to support it. So I think we're still going to have to wait a little bit longer for the Senate to act on these as well, because we need to wait for them to see if they can push that larger bill. If it's looking like they're not going to be able to have the votes to push that larger bill forward, then maybe we can see if we can get them to at least pull out the maternal health pieces that have already been passed in the House so that it can be passed into law, since there is such bipartisan support. So with that, now I'm going to turn it over to Michelle Lawler, the Director of the Division of State and Community Health at MCHB, for an update from the Bureau. Thanks, Michelle.
Thank you, Amy. And it's such a pleasure to be with you this afternoon. Dr. Michael Warren, the Associate Administrator, sends his regrets. As you know, he or Laura Cavanaugh, the Deputy Associate Administrator, usually does these calls, and unfortunately they had a scheduling conflict, so you get me today. But it's nice to be here. If I could have the next slide, please. And Amy, you actually covered some of this with the stopgap funding bill, the continuing resolution that was passed at the end of September, continues government funding through December the 11th. So what does that mean about your first quarter MCH block grant award? Many of you have been through continuing resolutions before, so you're probably familiar with this, but we will be prorating that first quarter funding to carry you through the CR funding period, which of course is December 11th. Also, the State Systems Development Initiative, which is SSDI, normally a December 1 award. Those awards will be partially funded at 19.73% due to the CR. So just for your awareness, I'd also like to just mention, we kicked off the MCH block grant review meetings this past Monday. We've had some, what I think are really good reviews. So far, so good with the technology. So for those of you we've met with, it was a pleasure. We enjoyed hearing about your programs, and then we look forward to meeting with the remaining states and jurisdictions. And if I could have the next slide, it is my pleasure to introduce today Dr. Reem Gandour. Many of you know Reem, I think, from some of the partnership meetings and AMCHP meetings, but Dr. Gandour directs the Division of Epidemiology and HRSA's MCHB's Office of Epidemiology and Research. I will say they're very close partners. We work very closely with the Office of Epidemiology and Research. And Reem actually oversees a range of investments that are targeted at extending, strengthening the data and analytic capacity, both at the national and at the state levels. And since 2013, she has actually overseen the activities related to the National Survey of Children's Health. So with that, I'm going to turn it over to Reem, who's going to provide us with a nice update on the National Survey of Children's Health and some work that's being done related to COVID-19. Reem?
Thank you so much, Michelle, and thanks to all of you for letting me sort of crash the party today. I recognize with all of the legislative and political activities, as well as your block grant reviews, the National Survey of Children's Health may not be the top of your list, but we thought it might be a good time just to give you a quick update on data release, which happened this past Monday, as well as to give you a preview of some of the content that we are testing right now related to COVID. So if I could have the next slide, please. So I suspect everyone is super familiar with this slide, but just as a quick reminder, the National Survey of Children's Health is sponsored and directed by HRSA MCHB. It is an annual survey and cross-sectional address-based survey, and we collect information on US kids ages 0 to 17 from their parents and caregivers. We do so by paper and pencil and web, predominantly web these days. And what's key about the survey is that we produce both national and state level estimates. So it's those state level estimates that actually go in and populate the estimates for 20 or so of the national performance and outcome measures for Title V. And our data are released annually on Child Health Day for the previous year. So this past Monday, we just released data for the 2019 NSCH. Next slide. And so if you want to go check out the data, you can do so through the HRSA website. Our URL is there. This is the access point to basically everything about the survey. It will bump you as relevant either to census or to the Data Resource Center or to data briefs that we have sort of pre-packaged for you. We have a number of data briefs that we did using the 2017 and 2018 combined file. And then for this year, we actually focused on mental and behavioral health. So there's a 2018-2019 data brief that's up there now that is new. And also I would just highlight, we just got our rural health data brief up there, I think in the last day or so. So those are sort of two new resources that are available this week. Of course, you can always get my contact information after the presentation if you just have some other questions about the survey or want to know how you can get to the data. Next slide. So I would be remiss in talking about the new data if I didn't actually show you some of the new data. So this is just a quick preview of what you'll start to see with the brand new data. This is 12 of the most commonly reported conditions. Again, these are parent-reported diagnosed conditions. And as it has been for many years now, allergies are the most prevalent, with about a fifth of kids reporting some kind of allergy. But what is most stark, and this has been sort of a trend that we've seen for some time now, is that the majority of these 8 out of the 12 most frequently reported diagnosed conditions are actually mental, behavioral, or developmental conditions. Next slide. So what I wanted to do here is just pivot very quickly to talk more about what we're doing in terms of testing some new content. I think, as I've probably said in previous presentations, we are basically in a 4-year cycle. So at any given time, at any point in the year, we are working on 4 different years of the survey. So if you think about where we are right now in the fall, we just released the 2019 data. We are monitoring where how the 2020 data are being collected. And I can tell you that so far, for better or worse, all of us being stuck at home is actually been a very good thing for the NSCH. So we have some good returns there. And we are planning for 2021 and 2022. And so specifically for 2021, we are testing content, possible content that we might include related to COVID. And so let me go to the next slide so I can talk a little bit about how we got there and what we're thinking about. So we're not, the only game in town when it comes to collecting data on COVID, as I think probably most of you know. There were 2 other sort of major, I would say, data collection efforts related to COVID. One was the Census Bureau's Pulse survey that went out in April, last April. And this is a web-based survey, entirely web-based survey. It does not produce state-level estimates. It produces the national level estimates that you've been seeing. And it's really designed to be a very rapid release data collection effort. So, and you've probably seen some of the estimates that come from this. So we looked at the Pulse survey. It continues to be in the field, and I'll talk a little bit more about that at the end of the presentation. And we kind of did a census of what they were collecting there. And as you can see on the slide, there was a lot of household type questions. So they were really looking at the kind of rough picture of impact of COVID through the Pulse survey. On the flip side, you have the National Health Interview Survey, which is sponsored by the Centers for Disease Control and Prevention. And they also added content in July related to COVID. And this really focused on foregone care specifically, but there was kind of a range of items. And so we did a very rough census of what was out there and then tried to think about, well, what other questions would we need to ask? What are the data gaps as they relate to kids and families with kids and kids with special healthcare needs? So that was kind of our first step. And then we reviewed our options for sort of what to do. We started this last spring. We ran into sort of 2 big hurdles. One was that there was no way for us to quickly cognitively test content, and we've actually had a pretty strong emphasis on always cognitively testing content before we add it to the survey. And second, we didn't want to delay the launch of the 2020 survey, which is now in the field, because it is the data source for the Title V performance and outcome measures. So we were trying to be sensitive to sort of different drivers that we were working with. And so what we decided to do was take a beat, develop some content, and test it, which we just started to do. And I just reviewed the results from the first round of cognitive testing last night. And so based on that, and I'm going to show you the items that we're testing in just a second, we will make some decisions about what we're able to actually include in the 2021 survey. Next slide. So here's where we landed. We basically picked items that fell into 3 categories. We wanted to look a little bit at testing and diagnoses. This is being covered by other surveys, so this was more content that we wanted to add as a benchmark so that we could kind of get a sense of how our data were comparing to other surveys that were collecting this kind of information. Then we wanted to add content that was specific to healthcare access and utilization for kids. And so this was where we were trying to get into the foregone or delayed preventive care. And we know this is so important, especially as it relates to immunizations, anticipatory guidance, developmental screening, things like that. And then finally, we wanted to add a set of items related to family impact. Perhaps some of that is driven by the fact we got a lot of parents on the NSCH team and we're all sort of grappling with a lot of impact. But this was the other area where we wanted to try to, again, fill in some of the gaps of what the other data collection efforts would bring to the table. What we learned so far from cognitive testing is that most of the items that we picked are playing relatively well. There are going to be some tweaks. I didn't have time to drop those into the slide deck because again, we just went over those, literally the call before this that I was on was talking to Census about possible changes to the items. So we're going to look at some different ways to refine the items, tighten them a little bit. The other option that we are exploring is trying to add child health items to the next iteration of Census's Pulse survey. We're not 100% sure if we'll get those on, but that's maybe another way for us to try to get some quick data on how kids and families with kids are experiencing COVID-19. So we're taking 2 complementary paths, one in the long haul, which is trying to get some additional content on the next NSCH, and that would be available to you. And then perhaps in a sort of short course, seeing if we can get just a handful of items on the next Pulse survey whenever it is fielded. Next slide. And that's it. I don't want to take up too much of your time because I know you have a lot on your agenda, but I'll pause now and see if there's any questions.
Hey, and as a reminder to everyone, we have, I'm sorry, there really is a bug flying around me, and given all the jokes about last night, I'm about to crack up. So you can unmute yourselves or type into the chat box, but I'm going to continue on with our presenters because we do have a lot and a full schedule. So Wendy, I'm going to turn it over to you now.
Sure, and I will be brief. First, Dr. Remley sends her regards and her best. She's sorry to miss this week's call. She had a conflict too. She did send our reminder that we all should get a flu shot, and that I have to confess that I was supposed to get mine 2 days ago, and then my child got a cold, so we couldn't go, which I guess is the reminder. I'll spin that into, you always need a plan B, so I'll be getting mine next week. Most of our time today, we're going to send over to Megan Lindley, who's going to talk about a publication that came out last week on Hep and flu immunization. So I have just a few updates to run through from the response. And I'm going to throw in one that's not response related, but I will use my speaker's leeway to just flag that from our center, from the Center on Birth Defects and Developmental Disabilities, currently has posted the NOFO for advancing population-based birth defect surveillance. It posted yesterday. It closes December 8th, and once I'm done speaking, I'll put the link in the chat. But just wanted to flag that for everybody. This is a multi-year NOFO. It's one of the biggest ones coming out of our center and one of the most important ones for ongoing birth defect surveillance. And there are a few changes from previous NOFOs that we're excited about and optimistic about the chance it will allow for us to look more into emerging threats and follow up babies. So COVID things to note, or COVID-esque things to note. There is a COCA call, which is the clinician's call underway right now related to flu prevention and treatment in children. So if you have any clinical folks, send them that way. It usually posts, usually by the next day if people want to watch the call. The response wanted to flag a few things that came out and are coming out soon. So when it comes to institutes of higher education, if you or your children are worried in college or universities, they wanted to flag that last week we did report some increases in COVID-19 among persons 18 to 22 and some clusters on university campuses. There was also a publication looking at trends in COVID-19 among school-age children. We also published considerations for testing, screening, and outbreak response for institutes of higher education and updated the considerations. Both the testing and the considerations were discussed Monday at the partner town hall, which should be online. I haven't checked to see if it's up yet, but usually it posts by today. When it comes to K-12, there were some updates to the considerations for K-12 testing and an update to the child care programs consideration. So that would be more your 0 to 5. And then looking ahead, the clinical considerations team is working on advice about COVID-19 for healthcare providers related to breastfeeding. And then because it's the season, it's election season, and as my daughter tells me, soon it's going to be Christmas season or the holiday season and Thanksgiving season. Because it's election season right now, we do have considerations for polling places and voting on our website. So if you have questions, please refer to them there. And soon we will also be updating our guidelines for winter holiday gatherings, and there will be a town hall later this month about what CDC thinks on that. And I don't know if we'll get into stuffing versus dressing and what do you call that, but maybe it will. And with that, I'm gonna send it over to Megan Lindley, who is the Acting Associate Director of Science for our Immunization Safety Division. And she's gonna talk about last week's paper. So Megan, over to you.
Okay, thank you, Wendy. Just wanna make sure first that I am audible-ish.
You're good.
Okay, wonderful. And I want to put in a strong vote that it's called stuffing. So thank you for having me join today. I'm going to quickly go over the high-level results from our recent publication on our annual survey of maternal flu and Tdap vaccination. And then hopefully there'll be some time for discussion either now or when all the presentations are done. And rather than just kind of run down the talking points, I decided, because it's a very good news, bad news report, so I decided that I'm going to present it by good news, bad news. And I'm an optimist, so I'm going to start with the good news. So the good news is that overall flu vaccination among pregnant women last flu season, so not right now, but in the 2019-2020 season, was 61%, and that's 7.5 percentage points higher than the previous season, which was 54%. And as I'm sure most folks on this call know, flu vaccination of pregnant women has been hovering in kind of that 50% range for years since the H1N1. So it was nice to see that bump. Another piece of good news that we're very excited about is that among the non-Hispanic Black women who responded to our survey, reported influenza vaccination coverage before or during pregnancy increased almost 15 percentage points from the previous season, so 53%, so a huge jump. And similarly, among Hispanic women responding to the survey, it was up 10 percentage points to 67%. And women of other race ethnicities, coverage was up 8 percentage points, also to 70%. So among women of non-white race and Hispanic ethnicity who generally have lower coverage, we saw in the past season very notable increases in reported influenza vaccination coverage. And that's something that we are very excited about. And obviously, you know, I want to caveat these by saying this is a single season of data that are self-reported from women. So obviously, CDC is going to continue to monitor this phenomenon to see if this is a data fluke or an annual fluke, or if it's real, but it's very, very encouraging news considering the significant racial and ethnic disparities in adult vaccination. Another piece of good news that I noticed comparing last season's report to comparing the 2019-2020 season, which is the one that I'm talking about now, to the 2018-19 season, the previous one, is that vaccination coverage is also overall lower among women who are publicly insured, so mostly Medicaid, of course, and women who are uninsured compared to women who are privately insured during pregnancy. And looking at the 2019-2020 data versus the 2018-19 data, there were notable increases in coverage in publicly insured women and uninsured women compared to the 2018-19 season for influenza. So I think that is really good news. The final piece of good news before I get to the bad news is that, as we have observed in previous seasons, vaccination coverage for influenza and for Tdap was notably higher, was highest among women who reported receiving a provider offer of vaccination or a referral to receive vaccination elsewhere. And it was around 75% for both. I guess it is 75% for influenza and 73% for Tdap. And that's good news because it shows that obstetric and maternal health providers have a real opportunity to make an impact on their pregnant patients by offering or referring them for vaccination. And Tdap, I did not go into as much because the news is not quite as exciting there. This past season, among the number of survey respondents who reported a live birth during our study period, about 57% reported Tdap vaccination, and that's actually pretty similar to what we saw last season. So we didn't see those that big change that we did to compared for influenza. So now for the bad news. The bad news is that despite that almost 8 percentage point increase in vaccination coverage, as I said, overall flu vaccination coverage among women who reported receiving it before or during their pregnancy was 61%. That means 40% of the women who responded to the survey didn't get flu vaccination in a timely way that could protect their newborns during influenza season. So the women may have been vaccinated after pregnancy, but it doesn't provide that important newborn protection until 6 months when the babies can get their own vaccines. So that's very disheartening, and there's obviously a lot of work to do there. And as I alluded to, the Tdap vaccination coverage reported was 57%. So the similar coverage, slightly over 40% of women did not get that Tdap vaccine during pregnancy, which would provide pertussis protection to infants at the point that they're most vulnerable to pertussis hospitalization and death. Another piece of, bad news is that despite those large percentage point increases in influenza vaccination coverage for non-Hispanic Black, non-Hispanic other race, and Hispanic women, there are still notable racial and ethnic disparities in pregnancy vaccination. And actually this season for Hispanic and for white non-Hispanic women, flu vaccination coverage was similar. But despite that nearly 15 percentage point increase in flu vaccination coverage for Black women, they had by far the lowest coverage. And I don't know if I said the figure, it was 53%. So you can see that already compared to that overall 61%, it's low. And then when you compare it to the coverage among white, non-Hispanic or Hispanic women, it's even lower. So there is still a real problem with specifically getting Black mothers and their infants protected against influenza. And similarly, Tdap coverage remained lowest among Black and Hispanic women compared with women of other races. Unlike the parity for white and Hispanic women for flu vaccination, Tdap vaccination coverage was lower among Hispanic women. And along the same lines, despite those increases in coverage I mentioned for publicly insured and uninsured women, they still had significantly lower coverage than privately insured women. And that's obviously a particular concern given that pregnancy is, of course, something that confers Medicaid eligibility. And I think part of the hope of that would be to provide pregnant women with the services that they need, including vaccination, to protect themselves and their infants. And finally, the last piece of bad news that I will leave you with before some potential action items is that despite what I noted about the much higher rates of vaccination among women who reported a provider offer or referral for vaccination, over 20% did not report receiving even a provider recommendation for vaccination. And these vaccines are and have been for many years standard of care. So it's simply critical that every pregnant woman receive a recommendation and ideally an offer or referral for vaccination from her healthcare provider. And so in terms of what might be done, CDC is currently doing some research to look more specifically at the kind of conversations that happen between pregnant patients and their obstetricians. We're specifically looking at obstetricians in this study to discuss what the conversations are that are happening in the room. Because even when you look at those women who did report receiving a provider offer or referral for vaccination, even limited to that group who we know are the most likely to get vaccinated, the Black women who responded to our survey were still less likely to report vaccination than the white or Hispanic women. So clearly there's some communication or some kind of assistance that isn't happening there that is at least partly responsible for that really problematic racial disparity in flu vaccination coverage. And I think in terms of action items, you know, the most important one is the one we always hit, but it really is the answer, which is that every healthcare provider who is providing care to a woman during her pregnancy has to emphasize the importance of these vaccines and has to give a really clear, strong, direct recommendation for vaccination. And something that we didn't highlight in the MMWR, if you read it too much, but that I think is really interesting, is, as I said, the coverage for both vaccines, for flu and for Tdap, is highest among women who reported either that a provider offered them the vaccine during their healthcare visit or referred them elsewhere to get the vaccine. But even if you look at the women who were only recommended, so their provider, for whatever reason, was not able or was not willing to offer them the vaccine during their visit, even if you look at women who only got the recommendation from the provider, their vaccination coverage is more than double those who didn't report an offer, referral, or recommendation. So even if a practice or a provider or setting, for whatever reason, isn't able to actually offer the vaccines to pregnant patients, just the act of giving that really strong, clear, direct recommendation endorsing the importance of vaccination for the women and their babies is huge. And I think that is all I have. So I will stop and say thank you very much for letting me join you all to present this information.
Thank you so much. We're always so grateful. I was trying to say the words glad and grateful at the same time. So grateful that we can hear not just from our usual partners at HRSA and CDC, but also to branch out to some of the other centers and divisions. And we're always talking about trying to model that cross-sector collaboration. So we like to do that on these calls as well. I'm going to turn it over now to our friend Kat Patterson from ASTO, who's going to tell us a little bit more about their VoteSafe project.
Thanks, Amy. Happy National Voter Education Week. I'm so excited to be here today chatting with you all. My name is Kat Patterson, like Amy said, and I'm a senior analyst at the Association of State and Territorial Health Officials, or ASTO. I'm happy to be here to talk with you a little bit about the VoteSafe Public Health Project, which is committed to promoting healthy communities and advancing health equity by assuring safe voting and participation in the electoral process. So this is definitely an issue that's come up more and more. And we've heard a couple of other folks mention that it's an election year, which yes, it very much is. Next slide, please. So the pandemic makes voter participation in elections an especially urgent public health issue. And there's really kind of three reasons that really kind of bring this point home. So the first is that those who are most impacted by COVID-19 are also those who experience the most barriers to voter registration and to voting. So we know that communities of color have been hardest hit by COVID, and we also know that those same communities, those same populations are most likely to be affected by practices like gerrymandering, like voter misinformation and disinformation campaigns. So there's very much overlap between who's impacted by COVID and who struggles to vote and to access the voting process. The second point is that civic engagement and participation in the electoral process through voting is itself an action that impacts health, either as a voter wanting to access the voting process and to cast your ballot, and whether you can do that safely and healthfully, or as election workers and poll workers wanting to operate those sites where people are voting, right, and trying to do that healthfully and safely as well. So there's been a lot of conversation this year about the poll worker workforce in this country is much older than the average, and what that poses in terms of being able to maintain the number of poll sites necessary in order to make voting an actual reasonable practice that people can engage in. And then the third point is that voting is, I would argue, has always been a public health issue, but is especially salient in that voting and poll sites specifically may be vectors for COVID-19 transmission. And that puts it very solidly into the hands of, into the purview of public health. And it was these three specific points that really inspired the establishment of the VoteSafe Public Health Project. Next slide, please. So the VoteSafe Public Health Project is a nonpartisan coalition of 10 national public health organizations, all dedicated to this issue of helping citizens vote safely and securely in this election while also reducing or preventing transmission of COVID. The focus areas are providing guidance and public health technical assistance to election officials and others involved in the voting apparatus, everything that goes into that, and making sure that it's safe. The second area is supporting efforts to recruit this expanded workforce, since we have experienced this dip in poll workers of this workforce not feeling safe, right? So seeking to expand that workforce, making sure that it has all of the tools and equipment, including personal protective equipment, in order to do their job safely. The third focus area is coordinating and amplifying communications and education efforts. There's a lot going on. Like I mentioned, there's National Voter Education Week going on. There's Vote Early Day, which happens later this month. So lots and lots of communications and programs out there. And the coalition really wanted to help coordinate and kind of provide a container for this booming conversation, really. And then the last focus area really, of course, is to encourage voter participation on Election Day, and that the public feels empowered and encouraged to do so and is able to keep themselves safe and healthy as much as possible. The coalition is really interested in strengthening relationships across organizations, working together collectively, and really bringing our experience as public health professionals to election officials, and really kind of connecting these two fields and seeing what is it we can do to promote safe and healthy voting. So next slide, where I get to brag a little bit about all of our great coalition members. Again, we are explicitly nonpartisan and focused on sharing guidelines and recommendations on how to safely vote during this public health emergency, encouraging voter participation, encouraging civic engagement through poll worker recruitment, and really focusing on the nuts and bolts of how do we do this safely. So again, we're a non-issue campaign. We don't support any candidate or specific issue. We're really just focused on keeping the voting process accessible and healthy and as predictable as possible, if I dare use that word in this year. On the next slide, I actually want to share a really neat opportunity. One of our coalition members, healthyvoting.org, is offering to ship printed materials of their healthy voting pocket guides and posters. These materials are also nonpartisan, state-specific, and available in both English and Spanish. And I don't think Zoom slides are clickable, so I'll have to see if I can drop that link into the chat here shortly. But if you're interested, please go to that link and you can fill out a request, and they'll send you these guides. They have, again, posters and then these little pocket guides. If you also wanted to do it one-off for yourself or potentially for friends and family, if you go to healthyvoting.org and look up your state, you'd be able to download that one-off. So here's your freebie for today on how to vote safely and healthfully. And we hope that you'll consider putting in a request for these materials. Healthy Voting says that these are especially useful in any setting where people are interacting with health and service systems. So testing sites, flu shot and vaccination clinics, hospitals, food banks, shelters, assisted living facilities, really any of these places where you have folks interacting with services. So that, thank you, Jess. I see the document coming through, or that link coming through. So please do submit as soon as possible. November 3rd will be here before we know it. And then on the next slide, just to see, if you want to see more about VoteSafe Public Health, if you have questions for us, want to join us, want to hang out with us, please visit asto.org/VoteSafe Public Health. We have social media tools for you to use, including graphics and sticker templates in both English and Spanish. We have sections tailored to voters, public health professionals, healthcare professionals, and election officials. We also link, among other resources, we link to the CDC resources on voting that Wendy mentioned a few minutes ago. So if you don't remember CDC's URL, maybe you can remember ours. But please reach out to either through the website or to reach out directly to our senior advisor for the project, Jean Ayers, at JAYERS@asto.org. We'd be really excited to hear from you. And then my next slide is just a reminder to please wear your mask, take your sanitizer with you, make a plan to vote healthfully. And thank you so much for the opportunity to present this. I'm really excited now to turn this back over to Amy to wrap us up with questions and then final announcements. So thank you. Thank you.
Awesome. Thank you so much, Kat. We really appreciate, and I know this was sort of a last minute request to ask you to join us today, so really appreciate you making yourself available, because I can't think of a timelier time to have this discussion. So we have time for Q&A. We have about 5 minutes left, so ask questions. You know, you can unmute yourself or type into the chat, but I also do want to just mention that our call for proposals is now open for the AMCHP 2021 conference. We are hoping for an in-person meeting. We know that, you know, we may have to change the format, but regardless, we will still be soliciting submissions for abstracts and posters. So please do go visit this link. It will be in the, and maybe Jess can actually paste it into the chat, but also it will be in the slides that you get after the call and available on the AMCHP website. We hope to have your participation in that as well. So please mark your calendars and think about submitting a proposal. Our next call will be in 2 weeks on October 22nd. I know that we will have some folks from Colorado planning to join us about their Medicaid waiver. If there's any other topics that you would like us to cover that we haven't done, or just, might want to share some of the great work that you're doing, please let us know. We'd be happy to have you join us for the next call. And I'll leave it open for like another minute, but I don't see any questions coming through. Great. Thank you, Noel, for appreciating our meetings. We also, I'm just going to put this out there, like, are starting to think about, do we want to still keep these bi-weekly, or maybe make them more monthly? So if you would all fill out the survey at the end, we didn't explicitly ask that question, but if you want to put it in the other comments, we'd love to hear back from folks who are participating if bi-weekly is getting too much, or if you appreciate having them every other week. We are happy to do either. We just want to make these as informative and useful for you. So thanks again. Don't forget to register, and we will see you next time. Bye.